So this is just a painting of HIV virus attaching to the CD4 cell and the receptor. This painting is owned by Dr. Eller.
I've seen it on his door.
If you all want to see it in person, just stop by.
In a few years, it's going to be a million dollars.
Very proud.
Oh, beautiful. Thank you. So I think this is a very important topic because, believe it or not, in these days, the leading cause of death in HIV patients is cancer, believe it or not. So it's going to become more and more important as the years pass. So it's important that you familiarize with this topic. So you can ask yourself why people with HIV are at risk for some cancers. Well, several reasons. For example, Kaposi sarcoma is associated with human herpes virus 8. Epstein-Barr virus causes some subtypes of Non-Hodgekin and Hodgkin's lymphoma. And HPV, especially the high risk, is associated with cervical, oropharyngeal, penile, vaginal, and vulvar cancer. Hepatitis B and hepatitis C virus both cause liver cancer. As you know, patients with HIV have a chronic ongoing inflammation. There is dysregulation of the CD4 and CD8. And those factors contribute to the development of some types of cancer. And this population have some problems and different type of lifestyle. They may be more prone to smoking, alcohol use, drug use, and high risk sexual behavior with multiple partners, etc. So patients with HIV are 19 times more likely to develop anal cancer, 3 times as likely to develop liver cancer, 2 times as likely to be diagnosed with lung cancer, head and neck cancer, and 8 times more likely to be diagnosed with Hodgkin's lymphoma than the general population, regardless of the T cells. And in addition to being linked to an increased risk of cancer, HIV is associated with overall risk of dying from cancer. They're also usually discovered when the cancer is more advanced and the overall prognosis is worse. Without counting that many of these patients don't have insurance, they are excluded from different clinical trials. So that adds more to the overall mortality of cancer. So antiretroviral therapy has decreased the incidence of certain type of cancers in HIV patients, especially Kaposi sarcoma and Non-Hodgekin lymphoma. And this is partially due to restoration of immune system. But even if you do, ongoing dysregulation still persists regardless of the CD4. But the overall risk for cancer is higher in this population. But the introduction of antiretroviral therapy has not decreased of other cancers they're not directly AIDS related or AIDS defining cancer. For example, lung cancer, liver cancer, and anal cancer. So the problem with HIV and cancer is that there is the perfect storm. There is chronic immune dysregulation. Some of these patients have an increased ratio of CD4-CD8 ratio, which could account for some immune dysregulation, decreased surveillance of oncogenes, etc. This population has increase of some oncovirus, such as human herpes virus 8, EBV, and hepatitis B. And these patients also have an accelerated aging. And so cancers that we typically see in elderly people, we see it earlier in HIV patients. a very nice review article that was published in New England Journal in 2019. And it's a review article about HIV-associated related cancers. And it talks about the epidemiology and the trends over the years since the HIV/AIDS epidemic started in the late 80s to 2018. We know that late in the 80s, as the AIDS epidemic started, they start seeing clusters of Kaposi sarcoma and aggressive B-cell lymphomas and also cervical cancer. And those were your classic AIDS-defined illness. Those were very high. The increase of these tumors were very high at that time. But as the antiretroviral therapy developed, once we start using 2 and 3 medications to fight HIV in the 2000s, other types of cancer start to be noticeable in this population. So first, we're going to talk about a little bit about AIDS-associated cancer. Then we'll talk about non-AIDS defining cancer. And I just want you to know that there are some incidental cancers that we're also seeing in people living with HIV. And I think we're going to learn more about this type of cancer as these patients live longer and we do more studies, including this population. So, compared to the general population, people infected with HIV are 500 times more likely to be diagnosed with Kaposi sarcoma, 12 times more likely to be diagnosed with Non-Hodgekin lymphoma, and 3 times more likely to be diagnosed with cervical cancer. And obviously, we're seeing more and more cases of anal cancer. So first, we'll talk about AIDS defining malignancy. So the big ones, Kaposi sarcoma, aggressive B-cell non-Hodgkin lymphoma, and cervical cancer. So this is a slide that shows you Kaposi sarcoma. So Kaposi sarcoma is very interesting because these patients are infected with human herpes virus 8 that infects the spindle cells in the epithelial spindle cells. Those overgrow. The HHV8 develops latency, and you can never eradicate this virus from these cells. These stimulates different variants of vascular proliferation, which is abnormal. And then that also induces cytokine production, and that leads to more and more inflammation, hemosiderin production that gives this purpuric discoloration. Now, it's important to notice that Kaposi sarcoma has the tendency to be developed more in the lower extremities because relative hypoxia leads to more proliferation of these cells with human herpes virus 8. And there are different types. You have the cutaneous form, and you have the mucosal form that develops in the oral tract, the whole GI tract from the mouth all the way down. You can have respiratory tract involvement, but you can also have different types of Kaposi sarcoma depending where you live. The classic form was first described in the Mediterranean, and patients not necessarily with HIV. It's elderly patients that have the typical Kaposi sarcoma lesions localized in the lower extremities. But you also have the endemic form more in the sub-Sahara Africa with multiple lymph nodes that have human herpes virus 8. In the United States, believe it or not, the incidence of human herpes virus 8 infection is not that much. It's only about 5% of the population. And in HIV patients, it's more commonly seen in men who have sex with men, in patients who are African Americans, and is more prevalent in the south part of the United States. So now, what about B-cell lymphomas? So the ones you see here with the star are the typical types of lymphomas that are AIDS-defined illness. And you can see that some of them are associated with EBV, like primary CNS lymphoma, and like non-HIV patients. Primary effusion lymphoma is very interesting because it's associated with EBV in 80% of the cases, but in 20% of the cases is associated with human herpes virus 8. And then you can also have plasmablastic lymphoma that is associated with EBV. So those are different, and so lymphomas are extremely complex, and Dr. Hanley already gave a nice lecture he gave a nice lecture about EBV. So as far as human herpes virus 8 or Kaposi sarcoma herpes virus, there are different type of presentations. You have the Kaposi sarcoma. We talk about it a little bit. It has been linked with primary effusion lymphoma, like I told you. But most of the time, this type of lymphoma is associated with EBV in 80% of the cases, but it could be co-infected with human herpes virus 8. And you also can see multicentric Castleman's disease. That is a widespread disease with splenomegaly, lymphadenopathy, and those is associated with human herpes virus 8. These patients may have hypoalbuminemia, hyponatremia, increased levels of interleukin 7 and interleukin 10. And of course, you also have the Kaposi sarcoma inflammatory cytokine syndrome of KICS. And these syndromes can overlap. So you can have more than one presentation in the same patient. And this last syndrome is basically a lot of cytokines with interleukin 7 and 10 without your typical lymphadenopathy or splenomegaly that you see in Castleman's disease. So you can have a Kaposi sarcoma patient with oral mucosa lesions or respiratory lesions and have KICS. So the next part, I will be talking about HIV, about non-AIDS defining cancer. This is a very important topic too because we're seeing more and more of these type of cancers as these patients live longer. We're seeing cancer of the anus, lung cancer, head and neck, Hodgkin's lymphoma, and hepatocellular carcinoma. And then we have incidental cancers. Those are multiple myelomas, skin type of cancers, MDS, AML, etc. So this was a nice study that we published in Moffitt. It was published in Cancer Control by our ex-fellow, Dr. Rihanna, and some of us. Basically, we include 279 patients. This was a retrospective study that was done from 2000 and 2010. And the idea was to see what type of cancers was more prevalent in this population. We included 279 patients, and what we found was that non-AIDS defining cancer was more prevalent in 60% versus AIDS defining cancer in 40% of the cases. What we found was that anal cancer was the most common, non-AIDS defining cancer, and AIDS defining cancer, B-cell lymphoma was the most common. And this just was a table, and that is that the blue shows you the non-AIDS defining cancer, and the red one, the AIDS defining cancer. So this is important to know how anal cancer is becoming really, really important. And the other one that's becoming really important is lung cancer, and I will be talking about that too. So this was another paper that highlights, well, basically this is the same review article that I showed you initially, review article, and this paper also highlights the important epidemiology that's happening with HIV and cancer throughout the years. So you notice also how people are living longer. So this shows you this table divided by age. This is younger than 40. And you see how these people, overall people were dying more in the 90s, but they start living longer. This age group remains stable, but people who are older than 40 are living longer and longer. And that may be why we're seeing more and more cancers. At least part of it, including accelerated aging. And these other tables show you, and this table is from the CDC, and that was highlighted in that review article that I was showing you. So you see how earlier this yellow table shows you age-defining cancer, and the blue, the red one, then the red one is non-age-defining cancer, and you see at the beginning, it was mostly, what we were seeing was mostly age-defining cancer. And throughout the years, it has these age-defining cancer have been overall stable, but the non-age-defining cancer are increasing as the time passes. Now, since we're talking about non-age-defining cancer, and the most important one is anal cancer, I wanted to discuss a little bit about this paper that's extremely well known. Is the ANCHOR study. And the idea of this study was to determine if the high-grade intraepithelial squamous cell lesions that are seen in the anal canal could be developed into invasive cancer, as it does in females with high-grade intraepithelial lesions in the cervical canal. So that was a motivation that the AIDS Malignancy Consortium had to develop this study. And they wanted to see if those two cancers behave the same, and to see if they can prevent that if they did resection of these lesions versus observation will prevent the development of anal cancer. So this was a multicentric study. It was done in 25 centers. And what they did, they include 5,058 patients. And it was randomized, and they divided in two arms equally. And one arm was observation. So these patients will have high-resolution anoscopy every year. And if they saw a high intraepithelial lesion, they'll just observe it, and they will do a biopsy every 6 months. And the other group was the interventional group, in which if they saw a high-grade intraepithelial lesion, they will resect it. How will they resect it? It will be using 5-fluorouracil, surgical resection, or laser. And this trial was stopped in September 2021 after they saw dramatic evidence of decreasing anal cancer in the group that had the intervention, the early intervention. So that's why this study has been extremely important in this group of patients. And many institutions recommended anal pap smears on HIV patients, particularly men who have sex with men, and females that have history of abnormal pap smear. Now, there's other studies that I didn't include here showing that females that even if they did not have abnormal pap smear and they're HIV positive, they can also have high-risk intraepithelial lesions. So the controversy still exists, and they have the regular screening hasn't made it to the big guidelines as far as screening. But at the VA, they do anal paps. I do it at Moffitt. And interestingly enough, most of my patients have abnormal paps. They all ended up going to high resolution anoscopy, and some of them, they do see high-grade lesions and they get removed. The problem is that in other centers, I don't know if they do anal paps. Sometimes they do it, but they don't know they don't have enough people to do high resolution anoscopies and to do biopsies. Some GIs don't do it, or they're not trained to do it because it's not the same as doing colonoscopy. And some ID doctors do it, but they have to, it requires, it's time consuming to be able to resect those lesions. You require a specific machine, a specific training, so it's not easy. Now, talking about lung cancer. Well, lung cancer is very interesting. And this is a nice paper, review article that was published in the Lancet HIV and in 2022, and it's discussing how these two groups behave, HIV versus non-HIV patients. And what we're seeing is, that the US task force recommends CT scans every year for all patients who are a smoker more than 30 packs a year, for at least, or even if they quit, for at least, if they quit in less than 15 years, they still have to do it. And that is to detect early cancer. Now, what is being noticed is that HIV patients have higher risk to develop lung cancer, and these appear not necessarily related to smoking history. So that's something extremely important, and there is controversy as to how do we screen these patients. Because there is also this other article talks about this particular difference between HIV patients versus non-HIV patients and lung cancer. They have detected that when the average of lung cancer in non-HIV patient is 54 years age, in HIV is 50 years. So the question is, number one, what's the risk factor to develop these cancers? And there is theories about the ratio CD4-CD8 that it's making this disbalance in the immune system, but they don't know exactly what's driving this, because it's not smoking necessarily, and it's not related to CD4. And so how to screen these patients is controversial, because you have to balance the amount of CTs that you're gonna get in a patient, the incidental findings that are not necessarily cancer, and all these interventions that you ended up doing that may be unnecessary. And I was even thinking, oh, maybe I can do a CT on my patients in the clinic. They're 50, but who's going to cover? Insurance may not cover for these CAT scan, because there was other papers saying, no, in reality, there is not that much of procedure that you will do, justifying, so the controversy still exists, but who's going to pay for those CAT scans?
So on a quick question, these patients, were they AIDS or were they HIV, they were controlled?
Yes, HIV control. And in fact, this is the second most common cancer in HIV patients, not AIDS related to control. So one of the controversial was, should we then just screen the patients that are with a CD4 greater than 500, because those probably are the ones that are going to live longer, and so they may be worth it, and that they are undetectable. So there is that controversy still goes back and forth, and I don't know what's going to happen. And I know Dr. Green sent an article about the immune dysregulation that is in the background of HIV right now. So those things is, it's very interesting to explore. So so this is just basically another paper illustrating how important is the screening and what happens when you are if you're HIV but you don't have history of smoking, and how you can see an increasing incidence of lung cancer. So again, it's one of the most common non-AIDS defining cancer in people living with HIV. It presents earlier than people who don't have HIV, 50 years of age versus 54. HIV is not only a risk factor, but it can holds a role because of the immune dysregulation, decreased surveillance of, etc. And normally, unfortunately, these cancers are discovered at more advanced state and therefore has worse prognosis in general compared to non-HIV. Yeah.
Is there a particular type of lung cancer that
Yes.
pops up?
Squamous cell.
Squamous cell is the most common.
Squamous cell, as opposed to adenocarcinoma. Great question. Again, in these patients, unlike other types of cancer that have been associated with HIV, there is no particular infected agent or virus that can promote this type of cancer. And going to your question, squamous cell is the most common. Smoking history is not always present. So what's happening in this type of cancer, we still yet to discover. And the screening methods are not clear at this time. Unlike anal cancer, now we're having a more clear picture of anal cancer based on the ANCHOR study, but lung cancer, we still don't know. What about, so the other type of cancer that we see in, that is non-AIDS defining cancer is head and neck. And head and neck, there are different factors. Number one is, particularly squamous cell is associated with HPV, but there are other factors associated with head and neck cancer, smoking, alcohol, which we know that can be more prevalent in HIV patients. But anyway, this paper was published in Clinical of Infectious Diseases 2023. And they review charts of many patients, thousands of patients. And among the ones that had HIV, that were only 48, they look at that and they saw that HIV patients had overall worse prognosis than the non-HIV patients, and they have worse outcomes. So head and neck cancer is also important. So I think Moffitt is going to be really busy in the next few years with HIV patients. Now, moving to a few other topics that are interesting in HIV and cancer therapies. So before, HIV patients were not included in studies for or treatment for autologous stem cell transplant or allogeneic stem cell transplant. But as early as 2011, they started doing autologous stem cell transplant. And this paper was actually done by some of our Moffitt oncologists. Dr. Ayala, he already moved to Mayo Clinic, and Dr. Chavez, he's still an oncologist at Moffitt. And they shared the experience that they had in patients who have autologous stem cell transplant at Moffitt, their experience with 20 patients. And they basically concluded that the outcome of autologous stem cell transplant was essentially the same as non-HIV patients. And same thing with allogeneic stem cell transplant. There is another paper basically concluding the same thing. So the outcomes as far as the risk of relapse, graft versus host disease, and other toxicities are not different than non-HIV patients. Those patients also are able to keep their viral load undetectable. So this is great news for HIV patients. Now, what about CAR-T? So these patients were excluded from CAR-T therapy until 2018. And then they start including them, and they realized that the outcomes were similar to non-HIV patients, including same risk of CRS, neurotoxicities, overall prognosis, chances of relapse or no relapse. So we're including more and more HIV patients on these types of therapy. There is still not prospective studies evaluating this population because, again, those patients were just started being included for these therapies in 2018. But this is a very interesting field of research because now they're exploring, can we do a therapy to treat cancer and HIV at the same time with using CAR-T? So those are things to explore in the future, and very exciting field. So what can HIV patients do to reduce the risk of cancer? Of course, they have to take the the antiretroviral medications, at least to decrease the AIDS-associated cancer. They need to quit smoking, alcohol, and drugs. They have to have responsible sexual behavior because, again, HPV is still there. HHV8 is still there. EBV is still there. They need to know their hepatitis B and C status, and this is also for us as a providers to be on top of their care. And they have to be updated with their cancer screening. We need to do more anal PAPs. We need to do more high-resolution anoscopies. We need to be able to resect these high-grade lesions right away to prevent the risk of anal cancer. And what to do for lung cancer is in the future. I think the future will tell. And that's the end. This is another one of my techniques. Yes. Questions?
Caballo.
Caballo. Yes. Of the bullfight. Yes.
Excellent talk, Anna. I have a question. So as you know, people with chronic HIV infection have a generalized increase in cardiovascular disease that is linked to chronic inflammation, and then there's a big fight as to how you follow it, what markers, blah, 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 blah. But everyone agrees that that's true. Has anyone used some of these, other indicators of inflammation like CRP or CD14 and things like that to look at risk stratification in lung cancers? Because certainly there's a long history of people getting, if people have had, say, TB or other inflammatory diseases of the lung, it's been known for decades that those people are more likely to come up with lung cancer. So has anyone done that with particularly lung cancer or any of these malignancies in HIV?
So what you mentioned is extremely interesting. I came across this nice article of a study that they did in Africa because they mentioned TB as a potential risk factor for lung cancer because lung cancer is also being seen in Africa. But to be honest with you, at Moffitt, I know we don't measure any of that. I know that at Moffitt, we're working with the AIDS Malignancy Consortium for these, to do different trials of HIV and cancer. But right now, what we're doing is screening patients with a history of smoking that I know of. But we're not that I know, but I have to read with more details those articles about all the theories behind the lung cancer, particularly related to these details of the immunological background.
Yeah, I mean, it's just like, I'm old enough to
So
remember all
fascinating.
but people, it's clear that, like these lung cancers that come from old TB scars and stuff like that, if you look at the older literature, it's definitely more than expected. But what that means is really hard to say. And even in the cardiovascular disease for HIV, everyone agrees that it's there, but is there enough of a correlation that you can use it for a predictive algorithm? Where I was in New York, there were a bunch of people who were studying it, and basically, right. I'd be curious if you can stratify who the highest risk, because then maybe you could do a CT or other monitoring
Without
on the
having to
highest
do it
risk.
at everybody. Yes, I think there was a paper that mentioned using the CD4 greater than 500 and some other things that were postulating that as a potential trial. So that way you don't have to do CT scans of everybody with HIV, but some populations.